Pleasure to be here, and I'd like to thank everyone for inviting me. I'm going to run quickly through some, I think, very exciting data and emerging technologies. If you're at Columbia, you're always reminded that you're underfunded, so that's my big disclosure. And I do serve on several of the steering committees for the devices I'm going to talk to you about. So as people have kind of highlighted quickly today, we have a burgeoning epidemic of heart failure, and I think that the major issue that we all face is that there's really too few of us to essentially adequately care for this growing population. And we've actually tried in the field to utilize, if you will, disease management techniques. And I think when broadly applied, these data would suggest that they're really a failure. Most notably, the largest trial that Sarwar Chowdhury and Harlan Krumholtz did in the New England Journal of Medicine suggests that, a telephone-based interactive voice system had really no effect on the primary endpoints, and the other endpoints are shown here. So, I think that, one-size-fits-all approach for the complexity of the patients that we're caring for is probably unlikely to be effectual. That's a theme that you'll come through. I do want to highlight, though, that those of us who work in the heart failure field recognize that probably the ideal patient is the one who we educate, who can essentially respond to some parameter, their weight or whatever else we're monitoring, and they have their own feedback. So they go to the bar mitzvah, they eat too much salt, and they know to double their diuretics, and they don't need to call us. And a lot of our strategies that we're using appropriately engage members of the team, but there's a much longer path to action. They need to call us, they need to contact us, they need to wait for us to look at the data online and decide what to do, and closing that loop may be essential in this particular area. So obviously, I think this is self-evident, but what you want to measure will then dictate what devices or things you use. So we can focus on patient symptoms by self-report or through telemedicine. Telemedicine utilizes scales, the old-fashioned, and what's emerging, and I'll talk to you about, are pressure sensors, both in the right ventricle, PA, and left atrium now. Cardiac output, Dr. Cotter, I think, appropriately highlighted the benefits of evaluating cardiac power, and I'll describe a novel device that we've been using here to better risk stratify patients for cardiac transplant. And then finally, I'm going to touch upon, I think, the most simple device, and that is a measure of human activity, which is essentially a wristwatch that you wear. So the LA PA pressure, years and years ago, right, Guyton taught us that the proximate cause of pulmonary edema is essentially an elevated left atrial pressure in the 1950s, and now we have the standard Swan-Ganz catheter that we can use to measure PA pressures, but not continuously, but an emerging set of devices from various companies that measure intracardiac pressures consistently. And you're probably aware of, quote-unquote, the CHAMPION study. This is a device that is placed in the pulmonary artery. It's a small little chip on 2 nitinol springs delivered by a PA catheter and can give you a waveform of the pulmonary artery. And here's a patient that's successfully treated based on these pressures that transmits the information to the clinician, and you make adjustments the practitioners do based on the PA pressures. Most of us believe that this was a wildly successful trial. This is the data from the Lancet published with a huge reduction, if you will, in hospitalizations and death. Number needed to treat was somewhere around 4 for every one of these devices placed. Having said that, I would just point out that the field has been recently rocked. These are the FDA advisory panel's conclusion that denied approval of this particular device. And I won't go into great detail, but I'm happy to talk to people offline. But this is what the FDA said. They were concerned that the study results were biased by the fact that, in essence, clinicians were using the information or giving counsel by the company about how to use the information. Obviously, this information, I think, needs to be used to take care of people, right? We can't use it in isolation. We need to incorporate it into our practice management. But this has really sent the world into a tizzy about whether or not these devices will be approved by the regulatory authorities. So a newer device that doesn't rely on the PA pressure but goes directly to the left atrial pressure is shown here. This is a device that's placed transeptally across the intraatrial septum and directly measures left atrial pressure. The beauty of this device, I personally think, is not the measurement of left atrial pressure. Neil Eigler, who developed it, is to be credited. It's really the idea that this is what we call physician-directed but patient self-management. The paradigm here is left atrial pressure is to heart failure as, if you will, blood sugar is to diabetes. And our endocrinology colleagues colleagues aren't essentially fielding phone calls in the middle of the night all the time, adjusting patients' insulin regimen based on their blood sugars. Patients are taught how to manage it themselves. So the device is placed here in the chest. A patient gets what's called a PAM, or patient activated module, and essentially puts it over their chest. It gets a little thing that says it's checkup time, how are you feeling, what's your breathing. They press start and hold the, if you will, iPhone right over the implant, and they get, or we get, essentially a pressure measurement shown here. This is an intracardiac electrogram, and this is the patient's left atrial pressure. They can get it any time of day. If they're at a fast food restaurant eating Chinese food and they feel short of breath, they can put this over and know what their left atrial pressure is, and it will show them the number as here, an LAP of 17. They're then instructed based on the physician-directed algorithm that's put in there, so you get to adjust what medicines you want them to take. So the concept here is, again, that a patient measures their left atrial pressure and receives a dynamic prescription that the doctor has essentially prescribed. Clinicians use a web-based trend, and as you can see here, you can dose adjust your diuretic based on the elevation or lack thereof of the left atrial pressure. Left atrial pressure is really high, take 160 Lasix, left atrial pressure is low, hold the diuretics. So what is the data in support of this? There's one small trial that's been published. It's called Homeostasis. It was a trial in which 40 patients were enrolled. The primary outcome here was freedom from major cardiac events related to, if you will, the device. And also there were endpoints related to calibration of the device, how well it worked in comparison to a wedge pressure, and control of left atrial pressure. So again, typical heart failure population, class 3, recent admissions, several relevant exclusions that are not ongoing in the currently a large randomized clinical trial, but were relevant to this trial. And that's interesting. So this doesn't show up very well, but essentially this describes the entry criteria of the particular population. The patients that were enrolled in the clinical trial, again, quite typical of a heart failure group, about 67 years of age, again, mainly systolic heart failure, and again, not displaying, unfortunately, very well, but cardiac outputs and indexes in the 4 and 2 range. The device calibrates very nicely, if you will, with measured left atrial pressure, and this is a Bland-Dalton plot showing that the device is quite accurate over time. And what we begin to learn from looking at these pressure tracings, if you ever have the ability or privilege, is that when patients have a markedly elevated left atrial pressure, you see this very large V wave from secondary mitral regurgitation. In this particular trial, the device-related complications were essentially non-existent, but again, it was a small trial with highly experienced, if you will, operators. Most importantly, this was the event rate, i.e. hospitalizations, ER visits for decompensated heart failure in the population before the device was placed, in an observation period after the device was placed, but not, if you will, turned on, i.e. the dynamic range. So we can certainly improve outcomes in patients by just enrolling them in clinical trials and taking good care of them, but there's a significant effect of the, if you will, patient managed but physician-directed left atrial pressure monitoring. And that's shown here, in which hospitalization rates, ER visits, and essentially all, if you will, episodes of acute decompensated heart failure were significantly reduced in this population. As shown up here, New York Heart Class improved, Minnesota Living with Heart Failure score improved, pulmonary capillary wedge pressure, as you would expect, came down, cardiac output improved, or cardiac index, and again, LV ejection fraction went up, and so did stroke volume. So there were significant clinical parameters that were improved without essentially a decrement in one's renal function in this particular trial. So, so you're aware there's a trial called Laptop. It's a large 700-person randomized trial, a single blind, in which this device is being tested. As of a week ago, there were about 180 patients enrolled in that particular trial. I'll just quickly highlight a construct of bioreactance. So you're probably well aware of the concept of bioimpedance. We put a signal into essentially the chest wall, an electrical signal, and changes in the amplitude of that particular signal are measured, and that's how we judge, if you will, cardiac output by bioimpedance. It has some important technical limitations. The amount of signal that comes out is temperature dependent. Obviously, in heart failure patients who are markedly obese, it can alter. Bioreactance relies on changes in the, if you will, phase shift of the electrical activity and the frequency. And it turns out, if this is, for example, the aortic outflow tract and the stroke volume is directly proportional by interesting experiments that were carried out by Dan Burkhoff and others in this particular phase shift. So you can non-invasively, if you will, estimate one's stroke volume on a beat-to-beat basis using this particular technology. The advantage of bioreactance to a bioimpedance is that there's improved signal-to-noise ratio, so in settings that we're all used to monitoring and evaluating patients where there's a lot of electrical, mechanical interference, it may be better. And again, there's conductivity issues where body size, motion, and other physical factors don't impede as much. The way that this device works, pretty simply, is there are proprietary stickers, 4 of them, that go on the patient's chest, typically on the back. As you'll see in a minute, an electrical signal is put in through each side. The voltage is recorded between the 2 inner pairs, and an input and amplifier records this phase shift. So these are data from actually humans on cardiopulmonary bypass. This is a flow probe on the aorta, and you can see the nice flow profile. And if you just go down to the signal that we're recording, it looks very similar. So you're basically getting the area under this curve and the area under the flow probe are indicative of stroke volume. And this correlates very nicely, the NICOM, with essentially PA-derived cardiac output. So if you think about the utility of this, we tend to judge who needs a cardiac transplant based on peak VO2. And we know that based on the Fick equation, peak VO2 is proportional to both peak cardiac output and AVO2 difference. And the assumption is that every large, deconditioned, overweight individual has a impaired VO2, has a low cardiac output. But that may not be the case, right? They could have a poor peripheral extraction and their cardiac output response would be normal. And so would such a device used during a cardiopulmonary exercise test help stratify patients? And the answer that we published years ago here is certainly the case. These are survival curves of patients who have VO2s under 14, typically used to identify people who need transplant, but good cardiac powers, and you can see pretty excellent survival up to 2 or 3 years, whereas those patients who have low VO2s and low cardiac power are those individuals you'd think about referring for cardiac transplant. And again, the area under the curve is significantly improved compared to peak VO2 using this particular technology. So last but not least, I'll just highlight this construct of actigraphy, which I think is simple, relatively non-invasive. We've gone from the most invasive to the least invasive, but may have a particular role to play, especially in the design of clinical trials. I can tell you the NIH and FDA are very interested. We all know in cardiology that we're very interested in one's functional capacity. So this is a sample device. There are hundreds of them. These are devices that are worn on the wrist like a watch. Inside of here are 3 piezoelectric crystals that essentially measure the motion of your arm throughout the day. The more you're moving around, the more energy expenditure you can detect. And actually at nighttime, theoretically, if you're sleeping, you're not moving around. These have been approved to essentially be screening tests for a sleep-disordered breathing. Here's a sample from a particular patient. The device can record with a single battery that's replaceable up to 90 days of data. So you can give the patient a device, they wear it on their wrist. And as you can see here, these are the individual activity counts that can be converted day by day to energy expenditure. So this person's active during the day and thankfully not active at night. And these are typical parameters. We've been using these devices. This is in a cohort that we published of 61 heart failure patients, essentially class 2 and 3, both with preserved and normal ejection fraction. I think the parameters here are typical of an outpatient cohort. And I'll just highlight that the device gives you the amount of energy that the person expends per day. That's hard to understand, but if you try to say, well, how much of your day is spent in vigorous physical activity, you would see that our heart failure patients spend 0.2 minutes. 0.2 minutes, not a minute, 0.2 minutes. And just so you have a sense, an average heart failure patient will essentially move their arm and have an activity count of about 250,000 per day. We've been using this in the TAVI population, getting aortic valves here, and it's obviously significantly reduced. And these are parameters that you get out of the device. The M.1 is one we thought of, which is essentially the maximum activity in 1/10 of an hour, which is 6 minutes. We tend to try to use a 6-minute walk time to judge people's capacity. M.5 is maximum half hour, maximum 10 hours, and L5 is the least 5 hours. So here's just a sample patient. These are her, if you will, L5, the least 5 hours of activity counts day by day that she's wearing this particular watch, and she reports that she's acutely short of breath, essentially has what you would say is PND or orthopnea. right about here, she's sitting in a recliner. And our activity counts, as you can see, the least 5 are now significantly elevated. She's ultimately seen in the clinic, her diuretic dose is adjusted, and she clinically feels significantly better. So these are ways that these devices could be potentially used. We've reported that the 6-minute walk distance is highly correlated with these particular devices, and I think they'll probably be entering into clinical trials as objective endpoints that people can measure. You put the watch on, patient comes back with them, and that's really the goal of NIH and the FDA. So I would just summarize this morning by saying there are a lot of emerging technologies that are both invasive and non-invasive for enhanced monitoring of patients with heart failure. I think they're likely to dramatically alter the manner in which we care for patients, but I would point out, be a clinician first. The only way to care for a patient is to care for them. So pick a device and different strategy for each individual patient, and they'll need to be tailored for the complex needs of all the people that we take care of. Thanks.